I'm Dr. G. Balamurali, and I'm going to explain to you about how I do an MIS TLIF in my own way. Now, the principles of spinal fusion is elimination of the pathological segmental motion and its symptoms by immobilization, a good fusion bed, and good bone graft. If you look at the biomechanics, the strength of the anterior load is about 80%, and hence an anterior spinal fusion is far superior to an isolated posterior fusion because there is redistribution of the weight-bearing surface, and according to Wolff law, the forces are much more anteriorly and a direct compression, and also there is an indirect decompression by increasing the height. Now let's talk about the TLIF technique as such. And for this, the preparation is you need to do a good pre-op workup, a consent. You need to have the proper appropriate instrumentations and the theatre setup. Now, the pre-operative workup, you need to understand which side you're going to approach. Is unilateral or bilateral? Is it more of back pain or leg pain? Is this a claudication type or a radicular pain? Based on this, you need to do decompression. You also need to study your imaging, whether the facet joints are involved, the stenosis, the disc is a problem, or the degree of listhesis. Consent benefits, the disadvantages, complications should be explained and be ready to open the surgery as well. So in theatre, you need a good C-arm, microscope, tubular retractors, instruments, bayoneted instruments especially. And instrumentation, you need to know the exact levels you're going to do, the screw, what type of cage you want, what are the preparation set, and whether reduction is required. And these are some of the basic instruments that you required and to be kept ready for the procedure. And light source is very essential. Either you could use an headlight or an endoscope or a microscope, but a light source is very essential when you're using through the tubes. Now, the key steps are the pedicle cannulation and K-wire insertion, the total facetectomy and root decompression, discectomy and end plate preparation. Then you insert the cage, and then you insert on top of the K-wires the screws and compress. First step is to get a good position of the patient in bolsters with protecting the various pressure points. And as you can see, also to strap the patient in two places because you will be rotating. Do an AP and a lateral X-ray to make sure that you are able to see the entire extent of your operative field, because you're going to be using a lot of radiological imaging for understanding your anatomy. Then you draw a grid on the patient's back, which actually involves the superior end plate, the pedicle, the medial and the lateral borders, as you can see in this image. So this will help you with inserting your screws and give you a rough guide rather than taking multiple x-rays. So the first step is the K-wire insertion with a Jamshidi needle, and the starting point is either the 2 o'clock or the 11 o'clock position with your needle. So the first point is once you place the needle, you know that this is on top of the facet joint, and then you gradually insert to the middle and then over to the medial border. And as you see in the midpoint of the pedicle on AP and lateral, you will see on the midpoint of the pedicle on both pictures. And when you go to the medial border on the AP, you will identify that you're at the pedicle and body junction. If this is not perfect, you should not proceed any further. And then when the K-wire advances further, and this is exactly how you are, and if the K-wire crosses the midline, then you know that you either have done a medial breach or you're not the right position. So the K-wire, once the K-wire is inserted, you check the level and positions, and this is how it looks when we're doing a 2-level TLIF, and then you do the tapping, and on the contralateral side, you can go ahead and do the dilations over the K-wire, the tap, and then insert the screws as well. There's a lot of controversy between which should be done first, whether the contralateral screw should be inserted or not, and it also again depends on what exactly is the pathology, whether there is a grade 3 or more reduction, if there is any further severe stenosis, or if you need to achieve a reduction or if you need to open up the space where you need a distraction. So various of these factors come into effect. So here you can see that we have placed the contralateral screws at two levels and the K wires on the other side. So for the decompression, in this case particularly, we're going to be doing an L4-5 TLIF only. So the incision actually is about 2 finger breadths or about 4.5 centimeters lateral to the midline on the side where you want to approach. And this has to be decided based on which side the patient's symptoms are more significant. So you make a skin incision which will extend over the facet. You use serial dilators over a K wire. With the help of an lateral X-ray, you would do this procedure, and you then keep dilating. You then measure the size of the retractor that you require. You can either use an non-expandable retractor or you can use an expandable retractor. So based on the number of levels you would go. A non-expandable retractor is probably preferable because it stops the muscle from falling in. And however, if you need to do multiple levels, then you may still need to use an expandable retractor. So once you have checked the position and you're happy with your dilators, and you then fix your retractor system in that same position. The first thing that you probably will be identifying once this will be muscles. Because the surface is not even, and in most of these cases the facets are degenerated and there would be muscle. So you can remove this muscle, bring in the microscope, and then from this point onwards you can do microscope. Here we are going to do a decompression of 2 levels and insertion of cage, and that is how you place the position. So I'm doing a decompression at this stage with the expandable retractor. So the TLIF is done where you're actually able to see the facet joint. For example, here at L4-5, you have the inferior articular surface of L4 and the superior articular surface of L5. So you do use an osteotome, and as it is shown in the red lines in the picture, you're going to do 2 cuts on the osteotome. And the reason I use an osteotome is so that you can preserve this bone for your graft, and you don't need to use any artificial bone substitutes. So once the bone is then removed and the inferior articular surface is also removed, and you can see the dotted lines which represent the pedicle, and it is very important that you don't cut through the pedicle, because if you cut through the pedicle, then you're going to have the screws exposed, an unstable screw, and biomechanically it's not strong and there's chance of screw cutout. So then you identify the triangle between the thecal sac on one side and the exiting nerve root. Now, how do you approach to the opposite side? You can tilt the bed, the table, operating table, and also the microscope away from where you are standing, and that's the view that you would get. So by tilting, you are able to actually undercut the lamina and the spinous process, so you can reach to the opposite side of the nerve root, as you can see in this picture. So it's very important that you actually strap the patient and fix him so he doesn't roll out of the operating table. So the fusion step is very important because the surgery is really meant for fusion, and unless you are able to achieve a good fusion, your surgery is not going to be successful. So the length and angulation of the curettes that you use are very important, and you need to be able to prepare and cause multiple breaks in the end plates without overdoing, because that could cause subsidence of the cage. So ideally, I feel that you probably would remove about anything between 60 to 70% of the disc when you're doing a preparation, and that would be sufficient in order to get a good cage. The cage should be placed as anterior as possible, in the weight-bearing surface of the large disc space. So once you've done the end plate preparation, then bone graft is placed and then a cage is inserted. Two types of cages can be used: a narrow cage, which is a long cage, or you could use a banana cage, which is got a slightly elliptical shape and can be rotated and placed very anteriorly. So the bone that was taken from the facet joint is used. I do a decompression after placement of the cage because I don't want to expose the dura until this point. So once this is done, so as you can see here, the cage is inserted, the screws now are put on the ipsilateral side, and these screws are inserted, and the rod is inserted. So in this case, we've done a decompression at 2 levels and then TLIF at 1 level. So the take-home message is patient selection is important, a good plan is important, the size of incision does not matter, a good fusion should be achieved, and you will get a successful result. Thank you very much.